Hello, I'm Jason Williams, a clinical instructor of hospital medicine and proceduralist at UCLA. Today we'll be covering arterial line catheterization of the radial and femoral arteries. We'll go over the indications and contraindications for the procedure, the equipment needed, step-by-step performance of the procedure, as well as the potential complications to look out for. An arterial catheter allows for more continuous, real-time monitoring of blood pressure, which tends to be more accurate than standard blood pressure cuffs. Arterial lines are commonly used in the ICU for severe refractory shock, hypertensive emergencies, and in the OR for high-risk surgeries. Arterial lines are also helpful when frequent arterial blood gas samples are needed for ventilator management in patients with severe ARDS. Contraindications to arterial line placement include inadequate circulation to the extremity, like cases of ischemic limb, severe peripheral arterial disease, vascular bypass surgery, or absence of a pulse. A history of Raynaud's disease, thromboangiitis obliterans, full-thickness skin burns, cellulitis over the site are also contraindications. Relative contraindications include coagulopathy and therapeutic anticoagulation. To further reduce complications, an Allen's test should be performed to ensure adequate collateral blood flow to the hand. Have the patient make a fist, occlude both radial and ulnar arteries, open the fist and release the ulnar artery. Color should return to the hand in less than 5 seconds. Greater than 5-second return of color is also a contraindication to radial arterial line placement. Arterial catheter placement should also be aborted after 3 failed attempts because the vessel is likely to be vasospastic after being traumatized by the needle. You should move to a contralateral radial artery or a femoral artery if initial placement fails. The equipment needed for the procedure will depend on which anatomic site is chosen. The radial artery is preferred given the dual blood supply to the hand. When radial artery cannulation is not possible, different equipment is needed for femoral artery catheterization. For radial artery catheterization, 3 techniques may be used. The first is the catheter over needle technique. The second is the catheter over wire technique, which involves cannulating the artery first with a needle, then threading a wire through the needle, removing the needle, then threading the catheter over the wire, and then removing the wire. This is also called the Seldinger technique. And finally, the third option is a combination of the two called a modified Seldinger technique. This involves threading a built-in wire through the needle and then threading the catheter off the needle and wire. The first step to place an arterial line, as with most invasive procedures, is to obtain and document informed consent from the patient or designated medical decision maker. Then perform a procedure timeout to confirm the patient, location, and the procedure, as well as the allergies and relevant medications, such as antiplatelets and anticoagulants, as well as labs like INR and platelets, and review previous arterial imaging of the extremity to rule out significant vascular disease. We'll begin with radial artery catheterization, and first position a towel rolled under the wrist to help flex the wrist and tape down the hand. Palpate the artery at or below the crease of the wrist. The use of ultrasound has been shown to decrease the number of needle passes and increase the success rate. Choose the linear probe for vascular access. Adjust the depth to magnify the vein, and adjust the gain to accentuate the vessels. The artery will be pulsatile and less compressible than the adjacent vein. Color flow can be used to distinguish the artery from the vein. Blue is blood flowing away from the probe, and red is blood flowing towards the probe. This can be remembered with the acronym BART, blue away, red towards. The CDC recommends a minimum of hand sanitizer, face mask, chlorhexidine skin prep, then open the kit in a sterile fashion, then place your sterile gloves, as well as a sterile drape. We will first demonstrate radial artery catheterization with the modified Selzinger technique, which uses the catheter over a needle that is guided with the built-in wire. Always use lidocaine in a conscious patient. Point the bevel facing up. The needle should enter the skin at approximately 30 to 45 degree angle, directly over the point at which the pulse is palpated. Once a flash of blood is obtained, it should be bright red and seen in the hub of the catheter. The needle should then be advanced another 2 to 3 millimeters so the bevel fully enters the vessel. Advance the wire and drop the angle of the catheter 10 to 15 degrees to make it easier to advance the catheter into the vein. Remove the needle and wire, and in a real patient you should see bright red pulsatile arterial blood. Connect your pressure tubing and securely suture the catheter and cover with sterile adhesive dressing. Now we will demonstrate a femoral approach to arterial line placement. Though you cannot perform an Allen's test on the leg, be sure to palpate for strong distal pulses in the foot to ensure there's no significant peripheral arterial disease. Femoral arterial catheterization is very similar to femoral central venous access. The vessel is much deeper than the radial artery, so the Selzinger technique using the needle, then a wire, and then advancing the catheter is recommended. The femoral catheter is also higher risk for catheter-related bloodstream infections, so full sterile protection is used just as central venous catheter placement. This includes face mask, hat, the chlorhexidine skin prep, hand sanitizer. Then open the kit in this sterile fashion, including placement of a sterile probe cover into the field. Then put on your sterile gown and sterile gloves, and fully drape the patient. And place the ultrasound probe sterilely into the probe cover. Identify the inguinal ligament which connects the symphysis pubis to the anterior superior iliac spine. The femoral artery is approximately the midline of the inguinal ligament, with the vein medial to it, but there is a large variability in the anatomy, and often the artery crosses over the vein, so ultrasound is recommended for femoral arterial access. Begin by inserting the needle at least 3 centimeters below the inguinal ligament, so if arterial bleeding does occur, the artery can be compressed. Arterial injury above the inguinal ligament could cause non-compressible bleeding into the retroperitoneum. Under ultrasound, the artery will be thick-walled, pulsatile, and non-compressible. With your probe over the artery, first insert your lidocaine needle to anesthetize the tract. Be sure to always aspirate before injecting lidocaine to make sure you're not in a vessel. Then pick up your ultrasound and place the artery back in the middle of your screen, and the artery will be in the middle of the probe. Place your needle in the middle of your ultrasound probe and begin to insert it at a 45-degree angle with the bevel up. As the needle is advanced, always gently pull back on the plunger. Use the ultrasound to follow the needle tip all the way into the artery until blood is aspirated. Remove the syringe, and in a real patient, note bright red pulsatile arterial blood. Then thread the wire into the vein and remove the needle while always maintaining a firm grip on the wire. Thread the catheter over the wire and then finally connect the pressure tubing and suture the catheter in place, and cover it with a sterile adhesive dressing. Recheck for warmth and color in the extremity after the procedure, and on a regular basis thereafter, and remove the catheter as soon as it's no longer required. Temporary occlusion due to vasospasm of the radial artery is common, but the more feared complication is prolonged ischemia causing tissue necrosis. Hematoma is a more common complication, usually requiring catheter removal and direct pressure over the artery. Less common complications include pseudoaneurysms, AV fistulas, compartment syndrome, and nerve injury. Arterial line placement is an integral skill in caring for critically ill patients. It's important to continue practicing under the supervision of more experienced providers. We hope you enjoyed this video, and I'll see you on the wards.